as much as I should be. So I'm Dr. Rohit Kochar. Venki, I think we have met in...
Yeah, sir, I know you very well, sir. Seen in a few conferences.
Yeah, so I am an alumni of Savita Dental College, Chennai. And currently I'm heading the Department of Cons and Endo in ITS Dental College, Greater Noida. This is in National Capital Region. That's very close to New Delhi. It's about 30 minutes drive from there. So that is about me, and let's know each other better. And what my suggestion I was just giving before Venki joined in, that this is a beautiful platform wherein we can very easily come in touch and come in contact with everybody, and you know, discuss some good articles, hand-picked articles, probably mutually decided by all of us. And it's a beautiful platform. And let our PGs also learn how, you know, to, you know, analyze an article. That will be very nice.
Yeah, I think now we have a very good opportunity because the president of APEC, which is Asian Pacific Endodontic Confederation, also is joining us. Hello, Professor Baber Kayahan. Good morning. So Professor Baber Kayahan is the president of, I think, Baber cannot hear us. Baber,
yeah, he's not able.
Yeah, I think he's trying to connect. So, but okay. Good morning, Baber. Yep, Professor Baber is the president of APEC, which is Asian Pacific Endodontic Confederation. And we had a chat about this platform with each other. And because there is also a connection for me as a member of the scientific committee of APEC, maybe we can ask this organization to support this type of communication in the future. I'm happy actually to host, as Tehran University of Medical Sciences, to host this activity. Obviously, with the help of APEC and the support of APEC, that would be more sustainable. Barbara, if you want to say some greeting, please go ahead, because of the time we are going to start.
Yeah, hey, hi, how are you? Good morning to you all. Mohammad, Professor Nekoofar, thank you for your kind words. I'd like to thank you on behalf of the APEC Education Committee. I'd like to thank you for this organization and for the invitation and for the collaboration. I hope in the coming days we will meet with more events, and all of us are very happy to be here. Thank you very much.
Good, thank you.
And I'd like also thank Professor Nagendrababu Babu for sharing his valuable knowledge and valuable time and valuable insights with us.
Okay, thank you very much. So far, I think we have many people from different cities in Iran, different cities in Turkey, different cities in India and Malaysia. This is really good. So officially, we are going to start this session of Journal Club. And Mr. Dr. Arvin Rezai, our resident, is supposed to present the article first. So Arvin is going to share his presentation. And this is an honor for Tehran University of Medical Sciences to have Professor Venkateshbabu as one of the very recent scientists who published a lot of articles recently in endodontic journals, as all of you know that. And he is expert in evidence-based dentistry and evidence-based endodontics, which is very important for us, all of us. So he kindly accepted to be with us in case that we have any question or any of you have any question. You may write it down in the chat room so everybody can see your question. And when we have the time for discussion, you may turn on your microphone and speak to us. And I'm going to ask whoever is connected to us now to turn on their video. Don't worry about the bandwidth, because the platform is very powerful. So we don't mind if everybody turn on their video. Then we can communicate better and in a real way rather than just a virtual, some names, and put your real name, change your name, rename yourself to your real name so everybody can call you. And from now we are going to call each other by our first name. Arvin, please go ahead.
Hello and welcome to you all. We are very pleased that you have accepted our invitation to join our journal club. Before starting my presentation, I want to express my deepest condolences on loss of our great Professor Ashraf. He was like a father for not only us in Tehran University, but also for all of Iranian Endodontics Society, and it was my honor to have patients with him when I was undergraduate student in Tehran University. May God bless him and enter to the heaven. So now let's go through our topic. My name is Arvin Rezai, resident or PhD student of Tehran University of Medical Science, Endodontics Department, and now I'm going to discuss about literature review meta-analysis with the title that is Efficacy of Local Anesthetic Solutions on the Success of Inferior Alveolar Nerve Block in Patients with Irreversible Pulpitis, a systematic review and network meta-analysis of randomized clinical trial. As you know, patients may experience a painful procedure if we fail to provide a successful anesthesia for them. This can lead to fear and anxiety in them, and it's also potential problem for them if we make our treatment long, or it may cause that we seems an inefficient clinician. So it's very important to provide them a very good and successful anesthesia. As you know, RCT of teeth with irreversible pulpitis are far more difficult from the other types that are asymptomatic or maybe pulp necrosis. So greater pain levels have been reported in them, and also it's very important to know, as you know very well, providing anesthesia in mandibular teeth are far more difficult from maxillary teeth. So because of that, this article has focused on the anesthesia of lower jaw's teeth. The inferior alveolar nerve block has been shown to be the most preferred technique to anesthetize mandibular teeth, but a very interesting point here is that its failure is between 43 to 83%. So it's very important for us that now that our technique has a high rate of failure, so it's very important for us to find this solution that's most effective and can provide us higher anesthesia. So as you know, another way to provide a good anesthesia beyond finding a good solution is to perform supplemental techniques such as buccal infiltration or PDL injection, intraosseous, and other kind of premedications. But in this article, we don't want to focus on these ways. We just want to find the good solution that has the highest effective and highest efficiency to provide us a good anesthesia. Yes, as I explained this previously, so it's various anesthetic solutions have been suggested to achieve successful pulpal anesthesia through the inferior alveolar nerve block in irreversible pulpitis. For example, as you see kind of examples that this article have investigated on all of these, and plus Lidocaine. It's not written here, but this article has also reviewed this solution too. Before this meta-analysis, several meta-analysis was conducted to identify the best suitable solution, but as we are going to see, their conclusions are contradictory and controversial with each other, and they are not, they have not make say the same conclusion. As you see in the first two meta-analysis, or better state articles, they reveal no difference in anesthetic success rate of inferior alveolar nerve block between lidocaine and articaine, particularly in the individuals that have irreversible pulpitis. But the other, let me change the place of, okay, but the other article have demonstrated that articaine had greater anesthetic effects compared to lidocaine. This writer 2 years before had demonstrated that mepivacaine had a greater anesthetic effect compared to lidocaine, given the same amount of vasoconstrictor. Another study in 2018 concluded that mepivacaine and lidocaine had similar anesthetic efficacy. As you see, all of the conclusions are controversial to each other, and they hadn't concluded the same thing. And because of that, to address this knowledge gap, a systematic review with a network meta-analysis was undertaken by Professor Venkateshbabu and his co-writers to identify the best anesthetic solutions for inferior alveolar nerve block with irreversible pulpitis. Before going to the rest of the article and going to method material, I want to give a brief explanation of the differences between meta-analysis and network meta-analysis. As you know better than me, a meta-analysis compares two intervention, but a network meta-analysis allows for comparison of more than two interventions, including also direct and indirect comparison of individual interventions, and also provide a rank of the different subjects that has been compared in network meta-analysis according to their probability of having benefits for us. A network meta-analysis has also, it's very important point, I think, that this kind of meta-analysis has considered to have the highest level of evidence in this decision making for us to making guidelines for our treatment. Okay, now we go through methods and to see how these meta-analyses have done.
Arvin, may I stop you, please? May I stop you, please? I believe the reason that you can see during these two sessions, we selected two very important articles with a lot of new things in that. The previous one was about a new analysis that Professor Venki explained that for us. And today we are speaking about this network meta-analysis. So before you go to the methodology, I'm going to ask Professor Venki to turn on his microphone and give us an introduction about this. And if anything that you want to add to the introduction part of the article, please go ahead. Venki, the stage is yours.
Yeah. Once again, many thanks for organizing this program. Okay, coming to the question, and most of their mind, you will have a doubt now. In this title, you have some other word called network meta-analysis. If you see the most of the papers in endodontics or any field, systematic review and meta-analysis will be there. So now in this topic, you have network meta-analysis. So now what you guys have to understand is, first thing, what is the difference between meta-analysis versus your network meta-analysis? I will explain to you in simple example now. For example, you have 3 drugs, okay? You want to know which drug is best, A, B, C. Got it, right? In case if you have any doubts, please ask me then, and okay, I will be going it in slow speed only. So as I told you, I have 3 drugs, A, B, and C. Now I want to know which is the best drug by using meta-analysis. Means meta-analysis means it's only pairwise. I can compare only 2 drugs. So now how I will be comparing A versus B, A versus C. This is meta-analysis. Now coming to network meta-analysis means I will be pooling the data's 3 data into that statistical tool. So I'll be putting A value, B value, and C drug value also. So the statistics will combine and give me the value which is best, comparing A versus B versus C. As I told you in first scenario in meta-analysis, it will combine only pairwise, A versus B, A versus C. If you see in this two combination, which is B or C, which is best drug? You got my point, right? So meta-analysis can compare A versus B, A versus C. But now the question arises, which is better, B or C? Because no studies has been available in previous literature. So now the ambiguity, now the knowledge of gap will come saying that which is better, B or C? To answer this question, your network meta-analysis will help you. So it will compare in all the proportions. Now it will give you the value A versus B, A versus C, B versus C. You got the point now, right? So it will pull all this data and again it will give you value. Here in network meta-analysis, you will have based on two evidence. One is direct evidence. As I told you before, A versus B, A versus C is your direct evidence because so far many randomized clinical trial has been published. So this is a direct evidence. No randomized clinical trial has been published between B versus C. So that's how the network meta-analysis will give you the information about indirect evidence, that is B versus C. This is the advantage of using your network analysis. Plus, it will rank your drug, rank 1, rank 2, rank 3. If you go still further this paper, in the results section and the supplementary data, I have ranked the drug. So it will give you which drug is the first. So that is the advantage of your network meta-analysis.
Thank you very much,
Clear
Venki.
for everybody?
Yep.
Dr. Babu, may I have a question?
Yes, please. Marriage, go ahead.
Can the number be increased more than 3?
Yeah, for example, I'm telling 3. You can use any number of interventions. For example, 19, 20, 100. Same way in one of our paper published in Journal of Endodontics, we tried with pre-medication about post-endo pain. I think it's in 2018 it was published. I think if you see that, more than 20 drugs we have compared. All possible combinations. Again, we have ranked the drug. We have included NSAIDs, opioids, corticosteroids, everything we have included. So we did that paper into 2. We break the paper into 2. One is main group, for example, NSAID versus opioid versus corticosteroid. The next part is we break down into individual drug, for example, ketorolac, paracetamol, acetaminophen, dexamethasone, prednisolone. Like that, we have break that. So you can include any number of interventions in your field. In this paper, I think we have included 5 interventions because the most common anesthetic agent used in endo is 5. Arctic and Lidocaine, bupivacaine, and prilocaine, I think.
Thank you.
Is there any other question about the introduction and this very unique methodology, network meta-analysis? If there is any question, please go ahead. Turn on your microphone and go ahead. Okay, there is no question, but I have a question. Okay, there's a question. Please, Sana, go ahead.
I just wonder that, is there a limit in the number for this network meta-analysis for the things, for the items that we're searching for?
Sorry, I can't hear your voice clearly.
But the
Is there a
question
limit?
about the number, is there any limitation for the number of medication that we want to compare in network analysis?
No. Network meta-analysis can take any number of interventions. It's not an issue. It can be 20, 30, 40.
Venki, I have a question. What about the techniques? I mean, for example, surgical techniques or the material that we use. Can we, for example, compare the success rate of different endodontic sealers or endodontic? Okay.
You can do. This is the basic principle. So you can accommodate this basic principle in whatever aim you want. For example, you want to know whatever is the best periapical material which you want to place, best pulpotomy material. You can do that.
Okay, but doing the
Principle is
network,
same.
yeah, but I can say something to everybody that is about the difficulty of running a network analysis.
Yeah.
Network meta-analysis is not an easy technique. Don't touch it easily. You need to be competent enough to do that. Definitely, you need Wenki as one of the co-author. If you decide to do that, contact him. Contact this guy. Okay, Arvin, go ahead.
Thanks. About protocol and registration, this review was followed the PRISMA checklist. The PRISMA, as you know, it's a checklist, or better say guideline, that when we want to do a meta-analysis, we have to follow this checklist. And also the protocol of the review study design was registered in Prosper database. Our PICO, as I said, was which is the most effective local anesthetic in these cases, that has been written here. Our search strategy and inclusion criteria, about this, the article has used two databases, PubMed and Scopus, and have included the articles until October 2018. The search was supplemented from the reference listed, included studies, published review, and also textbook. And it's an advantage for this article that has included also these to the investigation too. Following the initial search, we have used two independent, better say, Professor Venkateshbabu have used two independent reviewers, screened the title and abstract, and after that, a third one has joined to solve any disagreement between the two reviewers. As you see in this chart, 1,259 records have been found through the database searching, and nearly most of them have been excluded by just reading the title and abstract, and only just 13 articles have been chosen to read their full text, and after reading the full text of the articles, 2 of them were excluded, and finally 11 articles was qualified to do synthesis on them qualitatively and quantitatively. So our this article has done the meta-analysis on only just 11 studies. Our inclusion criteria and exclusion criteria, about this, we included adult patients undergoing root canal treatment in mandibular teeth with irreversible pulpitis, and also studies with at least 2 anesthetic solutions such as lidocaine, articaine, bupivacaine, and others, as a solution used for inferior alveolar nerve block on mandibular teeth with irreversible pulpitis. But an important point was that we excluded the studies that assess the anesthetic effect on inferior mandibular nerve block supplemented by infiltration anesthesia or PDL and other supplementary injections, and also the cases, the literatures or the trials that have used premedication to increase the success rate of inferior alveolar nerve block. Why? Because we just want to investigate on the efficacy of the solutions itself, not the other supplementations that have increased their success rate. So these two.
Sorry, Arvin, don't go. Please, just
Okay.
sorry to interrupt. No, go back to the previous slide, please.
Okay.
So if we look at the inclusion criteria and exclusion criteria, as Professor Wenki already mentioned that, we can see the number of different solutions in here. But what am I going to ask Wenki to explain again is the second bullet that we have. Studies with at least 2 anesthetic solutions, like lidocaine versus articaine, or lidocaine versus bupivacaine, and pilocaine versus mepivacaine. But my question is, we cannot find any study to compare all of these together. So now I'm going to ask you to emphasize on what you mentioned about the network meta-analysis, because doing the network meta-analysis gives this opportunity to put all the studies together. If we cannot find any study to compare all the list of the medication, meta-analysis itself cannot do that, but network meta-analysis is very unique technique that can help to compare all of them together and put this whole information, the pool of the data all together and give us some idea about what to do in the clinic. Wenki, please go ahead and use this sentence again to explain the technique. I mean the network meta-analysis, because I believe there are a lot of postgraduate students in the room with us. We need to go deeper to explain the technique better. Please.
As I said to you before, now in endodontics, you have this 5 anesthetic solution is most commonly used. Okay. Most of the randomized clinical trial will have only maximum 3 arms. It means only 3 anesthetic solution has been tested. For example, it will be lidocaine versus articaine versus bupivacaine. So it means, so other 2 anesthetic solution have not been studied in one particular study. So like that, if you see this particular paper, we have clubbed with 11 papers. In 11 papers, I think in one study, I think maximum 3 anesthetic solution has been compared. So it means another anesthetic solution has not been compared. If you see the spilocaine, I think hardly 1 or 2 studies only has been published. If you take lidocaine, most of the studies will be having lidocaine as one of the arm. So what network meta-analysis will do that is, it will put every anesthetic solution in the same platform. For example, lidocaine will have 11 studies. Spilocaine will have 1 or 2 studies. Articaine will have 6 studies. For example, I am telling. Okay. So this network meta-analysis will pool these 11 studies, extract the data from this 5 anesthetic solution. Then it will create direct and indirect evidence. Then finally, it will rank your anesthetic solution. For example, to my outcome, lidocaine is the number 1. Articaine is the number 2. Bupivacaine is the number 3. Spilocaine will be 4. Bupivacaine 5. So according to this ranking, we have to write our paper and give our conclusion saying that based on the network meta-analysis, one particular anesthetic solution scored number 1. So it means that is the best. So that is the answer for my research question. My research question in this paper is, which is the best anesthetic solution? So that will be my research question. If it have been a meta-analysis, how I would have been put in is, for example, I am taking 2 anesthetic solutions, lidocaine and articaine. So my research question is, comparing lidocaine and articaine, I want to know which is better. That is my research question if it's a meta-analysis. So just because it's a network meta-analysis, and I'm rephrasing my question is, which is the better anesthetic solution among all the anesthetic solutions?
What about the number, Wenki, what about the number of the studies that we need to do network meta-analysis? I mean, how many publications do you need for that purpose?
So again, it's not a hard and fast rule. So minimum, it should have at least 3 to 5. Then only the significance will be a little bit better. If it's less than 3 or 4, means you can do meta-analysis, network meta-analysis, but the output it won't be that good.
Thank you very much. Thank you very much indeed. That's very informative. I believe that is really very informative. Okay, Arvin, go ahead.
Thanks.
Arvin, can you explain for us the exclusion criteria again, please?
Studies that have assessed the anesthetic effect of inferior alveolar nerve supplemented by infiltration anesthesia and studies that use premedication have been excluded. Why Professor Venkateshbabu have done this? Because he and his co-authors just want to emphasize on the effectiveness and efficiency of the solutions. They didn't want to, because you know here supplementation techniques such as infiltration, buccal infiltration, PDL injections, premedications, in the researches, we call them confounders, because they have effects on our subject that we are going to investigate on. So these authors have excluded the trials that have used these supplementations to just find out which solution itself has the most success rate comparing to the others. So because of that, they put this exclusion criteria to find out just the effect of the solutions. Can I go ahead? Outcome measure, microphone. Professor, microphone. Your microphone is off, Professor Nekoofar. Professor Nekoofar.
Sorry, yes, sorry guys. Okay, what I'm going to emphasize, again, please go back to the previous slide, Arvind, sorry to interrupt you. The importance of the exclusion criteria, because as Arvind already mentioned, and I think I could see the Venki's face that confirmed whatever Arvind said about the exclusion criteria, because this is also very important. We don't want actually to mix data all together and conclude something wrong. We want actually to conclude something definitely scientific. And this is the reason that we need to exclude some of the studies from the network meta-analysis. As you can see here, if we have a premedication, then we cannot compare the use of, for example, lidocaine with premedication with others. So is there any solution for that? Because Venki, as you know, many of us use premedication as well. So what we can do in this situation, what do you think?
Here, as Arvind said, why I have excluded all these studies is to restrict and focus my research question. If I included the supplemental technique, some other anesthesia technique like Gaugates or that can also be possible. Plus, other way, as Prof. Nekoofar said, is pre-medication. So if I'm putting all this parameter into this one particular study, I am distracting from my focus. My focus is only which anesthetic solution is the best. So to give answer for that, what I did, I have asked other external factors. So for example, if Prof. Nekoofar wants to know which is the better pre-medication, then his focus has to be only saying that among the pre-medication drug, which is the best pre-medication drug. So in that also, again, he has to ask supplemental technique and other technique, what are all which influences your outcome. So all parameters here you have to ask this. In this study also, even though I am using this anesthetic solution, I had little bit of problem. For example, quantity of anesthetic solution might influence. For example, in one study, lidocaine would have been used for 1.68 ml. In another study, they would have been used 2 cartridges, that is around 3.2. So how I solved this problem is I did subgroup analysis. For example, in this study, I am comparing only with 1.8 ml. Another study, I am comparing with only 3.2 ml. So with that also, we did a subgroup analysis in this paper. So then we came to conclusion with focusing all the subgroup analysis, which is the best anesthetic solution I used.
Thank you very much indeed, very useful. Okay, Arvind.
One question,
okay. Professor Rohit, please, yes, please, go ahead.
Venki, as we know that inferior alveolar nerve block is very, very technique sensitive. You know, some subjects, would have, hit that area and some would not have hit that area because of the anatomical variation, I believe.
Yeah.
So how did we cover that aspect? It's very important. The solution will be very strong.
Yeah. See, here my focus is, I'm not saying how to improve the anesthetic solution efficacy. My aim is among this inferior alveolar block, which is the best anesthetic solution. So the answer for Prof. Rohit Kocha's question is, I have to include all this parameter in one particular study. For example, various supplemental technique, various anesthetic techniques, and various anesthetic solution. Then only I can give answer. For this particular study, in inferior alveolar nerve block, we know that the failure success rate is around 43 to 80. How to improve the success rate, that's all, with anesthetic solution. So we can't give any other external aspect in this particular paper.
No, my question was something else. I am saying that if you do a meta-analysis, you have covered all these studies that research has done on this particular solution. All right.
Okay.
Now
Yeah.
those studies would have they included this particular parameter, that whether the technique was right or not. If they have some parameter wherein they say yes, this technique has to be used and it has been used correctly in this particular subject, only those cases or those studies have to be included in meta-analysis. Do you get my point?
You're saying how the outcome has been measured, Prof.
Exactly.
No,
Was that
Venki,
a parameter which you included?
I think Professor Rohit tried to say that when we inject inferior alveolar nerve block, it may not be successful because of the technical issue of the injection, because of the medication. How do you measure this issue? Am I right, Rohit?
Yes, perfect.
Okay. In that case, then you have to go for supplemental anesthetic techniques. So for example, if the inferior alveolar block is not working, then we have to think about additional infiltration. For example, buccal, lingual, or periodontal ligament.
Oh, Venki, I'll come in on this. I think the question is not understood well. Supposing I am doing a research at my place, I have published an article, and I have done the study on the efficacy of this particular solution, maybe 1 or 2 or 3 or 4, whatever it is.
Okay.
And I haven't included a parameter wherein I can successfully say that this was the right technique to be used, and this subject has undergone that anesthetic effect, effectively. So if my parameters are wrong, how have you included or excluded my kind of a study which is not up to the mark?
Excuse me.
If I help Venki for that purpose, I can say something, and Venki, can you correct me please if I am wrong? Right. I think one of the important things before we go ahead for the analysis is the systematic review. And in the systematic review, we look at an article and criticize the methodology. If the methodology is not right, then we need to exclude that data. So I think last week also we discussed such a things. If one article is not powerful enough in terms of the methodology, in terms of concealment or blindness or whatever, we need, so we discussed a lot about the allocation concealment last week, or blindness, or randomization, or as you said, technical issues. If there is anything like that, we need to go ahead and read the text, full text of the article, and exclude that because the technique is not good, because or because the article is not valid enough. It is my understanding. Am I right, Venki? And I think
perfect. So was that done or not? My question is, was that procedure followed or not in Venki's article?
Yeah. We have to read all those papers, then we will put a checklist what are all the parameters will be included. If you see this next slide, he will be talking about the outcome measure. So how the outcome measure also will be taken into consideration. So if the paper satisfies all your criteria, then only the paper will be included. For example, somebody is giving inferior alveolar block in some other different technique, which you think that is wrong, that paper will be excluded.
Excuse me.
Yes, please go ahead.
Yeah. What about the effect of the operator? Who is doing the anesthesia? Is this a criteria in inclusion or exclusion?
I think it is very similar to the question of Rohit, the effect of the operator. That is good. Venki, please.
The technique is different, and the operator is also different.
Yes.
Right operator, wrong technique, for example.
Yeah. I think, Venki, sorry, Venki, before you go ahead, I'm going to ask Arvind to answer this question, because Arvind is going to give a mark. We need to give him a mark at the end of this session. So, Arvind, what do you think? You should answer this question that Professor Kayahan asked.
For example, the experience, 5 year, 10 year, what is the experience?
As Professor also Rohit have mentioned, this all also operator and also the technique, the techniques correctness is the I think it's the inherent or it's a problem in all of the studies we have. I think in my opinion, as I know, we cannot solve this problem because we could not know the operator have done the technique wrong or the solution is bad, and I mean
excuse me, apart from the anesthesia technique, maybe the experience of the operator.
Yes, you're right. I mean exactly what you're saying, because you know we could not exactly know that our solution was bad or our clinician has failed to done the correct. But one solution that has burned in mind when the professors were speaking, were discussing with each other, can we use the signs of anesthesia, like the
That's the best way to do. That's the best way to do.
Yes, like numbness of the lip and tongue, we find that our technique was right, so we can be more confident about when we are as a meta-analysis.
For example, eyes test or sensibility test, like tests.
Yes, yes.
Okay, Wenki, please put them together because we want to go further.
Okay. The thing is, the answer for his question is, he's saying the operator efficiency can influences the outcome or not. If I'm wrong, this is his question, right? So
yes,
for example, right?
Yes,
that is your question. Okay, to bring that parameter into meta-analysis, to whether to include or exclude, we should have a strong evidence saying that the inferior alveolar nerve block with an experienced operator efficiency is more. So for that, how a randomized clinical trial should have been performed initially. In one group, inferior alveolar nerve block should have been given only with less experienced operator. In another group, you would have having the inferior alveolar nerve block would have been given by experienced operator. Then the result would have been whatever might be good or bad. In case if we have a results like that only, we can bring that parameter here to saying that the influence of experience of the operator might alter your outcome. But unfortunately, I think I never have seen any such study saying that operator experience will influences or affects your success rate of inferior alveolar nerve block. So that's why we have never brought that parameter into this inclusion and exclusion criteria.
Thank you. Thank you very much.
Okay, Arvin, go ahead.
About our outcome measurement, success of anesthesia was assessed during access cavity preparation and also pulpectomy in the mandibular teeth diagnosis that have irreversible pulpitis, and we assess the success during these two procedures. About quality.
One second, Arvin, can you go before slide?
Okay.
Sorry for interrupting you.
Okay.
So this is,
you should do that.
Yeah, this is one of the important aspect which you have to listen here is, here my focus, my outcome measure is only two things. I am testing the anesthetic efficacy only during access opening and pulp extirpation. If you see most of the randomized trial, the anesthesia of your inferior alveolar block will be checked by, first method is lip numbness, correct? Second is, most of the studies would have been tested with pulp sensibility test alone. For example, heat, your cold, and EPT. The third aspect will be access opening. Fourth final parameter will be pulp extirpation. Why I excluded the other first two things is, most of the studies says lip numbness will be there, which most of the endodontists will agree with me. In clinical point of view, before starting the access cavity, patient will say, my tongue and my lip is numb. We think that the success of inferior alveolar block is done. Then while our burr or hits the teeth, what happens? Patient says, I have a severe pain. So what does it mean? Even though the lip numbness is achieved, the most important for an endodontist is to anesthetize the pulp. That pulp is not getting anesthetized. So coming to this meta-analysis, which is very important for me, I have to complete my access cavity and my pulp extirpation. That is more important for me rather than the pulp sensibility test. So that's why we excluded all the studies which they are using the lip numbness as and the electric pulp sensibility test as a indicator saying for success and failure of inferior alveolar block. You got the point?
Yes.
Yes, thank you.
Yeah. So that's why this review clearly says this is the better anesthetic solution which works out for my access opening and pulp extirpation procedure rather than lip numbness and pulp sensibility test values. So all those things it will be covering in your systematic review. With that review, you have to put in your how strong and how focusing is your outcome measure is.
Yes, thank you.
Thank you very much, Venki.
Yeah.
Arvin?
Okay. About quality assessment, we have Cochrane risk of bias tools of randomized clinical trials. 2 independent reviews are supposed to assess the quality of the studies, and any agreement is solved by the third reviewer. As you know, quality of the articles are categorized into low, some concerns, and high risk of bias. Based on what, if we see any concerns in randomization, deviations from intended intervention, or missing outcome data, outcome measurement, and selective reporting results. If we see any concerns or any problems in these areas, we could have some concerns on their quality. Overall quality is assessed based on the score in individual domain. When all the key domains are okay and they don't have any risk, we put the article as low risk of bias or have good quality. But if they have any concerns in at least one area and one key domains, we put this in some concern articles. And if a study was high risk of bias in overall quality, it's when that it has a high risk in one of its key domains. It's the protocol to how we put the articles into a low risk of bias, high risk of bias, or the articles that have some concerns in them. As you see, there's a protocol which with abbreviation of GRADE, that is abbreviate of the grading of recommendation, assessment, development, and evaluation. That is a protocol to rate the quality of the evidences. It's used to objectively rate the quality of evidence obtained by the analysis. The quality of evidence here is divided into 4 qualities. It's high, moderate, low, and very low, as you see in the chart. When the quality of evidence is high, the author have a lot of confidence that the true effect is similar to estimated effects. But when it's moderate, it has doubts that is maybe probably it's close to the estimated effect. But when it's low and very low, the effects might be markedly different or completely different from the estimated effects. No questions in this part? Can I go ahead?
Venki, do you want to add something to that to complete this?
As I told you, here we use the grade analysis. As I told you the last time, grade is
go back to the previous slide. Yes, please.
Yeah. Grade is a type of assessment, it's a statistical tool, it's a free software. So for grade, you need few parameters which you have to key in. For example, number of samples, what is the quality of the studies, and all those information we have to key in. So automatically that statistical tool will give us what is the level of evidence. For example, the results of this particular meta-analysis, evidence is high. For example, if I'm comparing MTA and biodentine, MTA is a better material, but the quality of evidence is very low. So what will be my future is I need to perform high quality research. So that is the take home message from your grade analysis.
Thank
Any
you.
other doubts? Yeah.
Yes. Professor Nekoofar,
Sorry, yes. Sorry, I
Reza
think
Mahmoudi has raised
Mr.
the
Reza
hand.
Mahmoudi wants to ask a question. Please go ahead, Reza. One of the participants, Dr. Reza Mahmoudi, raised his hand to ask question. Please go ahead. Okay, I think, Reza, you can, I think because you raised your hand, I think you want to ask some question. Is there any question so far? So I want to emphasize on this take-home message again about this grade part, which answer many questions. I think this part is very, very important before we do any analysis in any technical things. So this is very important. We need to be expert to do that. So this is very tricky part because you may select something and other may select something else, or you may rank it as high, but other may rank it as moderate. So this is the important issue. And I think it is very important, and you need experienced people to do the criticism and there's critical appraisal before we go ahead for the analysis. Am I right, Wenki?
Yeah, because in your conclusion, the quality of evidence will be clearly mentioned. So that is the take-home message for practitioners. For example, my quality of evidence is low. Means what does it mean? It means the evidence is not that strong enough. For example, if I'm saying that the evidence is high, is better, so means the take-home message will be better. So we have to be very careful in keying all the information in this particular tool. So that's how your output will be transferred.
Okay, I think there is another question as well. Please go ahead, Dr. Ramzani. Mohsen, you raise your hand to ask a question. Please go ahead. We cannot hear Mohsen. Mohsen, I think when you technically connected, you can ask your question anytime. Okay, Arvin, you go ahead while Mohsen try to connect.
Dr. Nekoofar. Dr. Nekoofar,
You must please, yes.
Hello to everyone. I have a question. Professor, is it possible to show me the reference for this software that you use to rating the quality of evidence? Do you have any reference for this or published data that we can use? And is it possible to share us the PDF form of this information?
No, I think in the paper we have given the website for that Grade Pro software. You just put it in your URL, automatically it will give you all information. So you have a regular handbook for that. So if you read that handbook, it will give you information how to use your grade.
Okay, thank you very much.
Yes.
Wengi, is there any particular way to do that in endodontics, or grade is a general thing? Are you going to do something about that?
No. It's exclusively for any field. So you can't customize your grade only for endo or some other thing. So it's a general thing, we are using it up. Like the risk of bias is for medical and dental field.
Okay, Arvin.
Now let's go through the results. We have a lot to discuss here. First of all, let's discuss about this table. It's a large table, as you see here. Here has 11 studies and the mean ages of the participants. Here has written the gender of the participants, how many male and how many females that has been put into the trials. In this column, it's been mentioned the solutions, and at the last column, how many successes have been reported in the trials, and this is the tools that have these operations have been done. I try to mention to just important and key points here, because as you see, it's very large. As you see in the first trial, three solutions have been used for the first and second mandibular molars. Lidocaine, articaine, and bupivacaine has been used, and as you see, the success rate for articaine is the highest, and after that, lidocaine and bupivacaine are second and the third solutions that has been reported as the success rate for these three solutions. The next article has used mepivacaine and lidocaine on these three mandibular tools, and as you see, mepivacaine has higher rate of success than lidocaine. So, and after that, the third article has used articaine, lidocaine, and mepivacaine in it, and it's been concluded that articaine is the second one, and mepivacaine is the first, and again, the lidocaine has the lowest success rate comparing to mepivacaine and articaine. So here, as the above article, mepivacaine is the highest, and after that, articaine and lidocaine are second and third solutions that in success rate. Here, I'm just speaking about the success rates that have been found, but it doesn't mean that it has statistically significant results, and it will be shown in the next parts that have been meta-analysis. But here, just now I'm speaking about the numbers, about the success rate that has been reported in the articles, but as you better know than me, it doesn't mean that these successes have statistically meanings, and it's very trustworthy. At the fourth article, lidocaine and bupivacaine has been compared, and as you see, just one more success rate for lidocaine has been reported, more than bupivacaine. But in this study, in the seventh study, it's been completely controversial result, and it shows bupivacaine more than lidocaine. And as I mentioned before, the results from the different articles, in some parts, not all of the parts, but in some parts they are completely different. As you see, the above article showed that lidocaine is more efficient than bupivacaine, but the under has been completely opposite. The fifth article have compared lidocaine with two different concentration of epinephrines and articaine with each other, and as we see in success rates, articaine has the most success rate, and the lidocaine with the higher concentration of epinephrine is the second one, and the lower epinephrine of lidocaine has the lowest success rate. In the other study, articaine and lidocaine have been compared with each other, and again, articaine has the higher success rate compared to lidocaine. And in the I explained the seventh article. I skipped this and I go through the eighth article. It has compared articaine, lidocaine, and prilocaine with each other, and also mepivacaine. And as you see, mepivacaine has placed in the first, and the prilocaine and articaine are at the same time in the second place. And again, lidocaine has the lowest success rate. The ninth article have again compared articaine and lidocaine with each other. Again, articaine has higher success rate compared to lidocaine, and 10th study again done the same operation, and again the same result. Articaine has higher success rate compared to lidocaine, and the last one has compared again articaine and lidocaine with each other, and just one success rate has been reported, but it's important to notice to the total sample size. As you see in all of the studies, the sample size in one study are the same. As you see here, 21, these 3 are related to one study, or 22. As you see, at the most of them, the sample size related to one study are the same. But in the last article and the first article are the only articles and only trials that have different sample size in themselves, and I think it makes a problem in interpreting them, because as you see in the last article and trial, we have just 1 more success rate, but the sample size is 2 more. So I think, in my opinion, as a reader of a article, I cannot conclude that articaine is more efficient than lidocaine, because its sample size is 2 more. That was all about this table. If no any question, I can carry on.
Wenki, do you want to add anything? Wenki, microphone, please. Microphone.
Yeah. Sorry. As I told you before, if you see, this is the characteristic table which explains you what are all the groups you have been included. If you see that 8 study as the only study has compared this 4 anesthetic solution. Whereas this first study by Vivek Agarwal et al., he had combined only these 3 anesthetic solution. It means lidocaine, articaine, and bupivacaine. So another 2 anesthetic solution has not been tested. So like that, if you see all these 11 study, 2 or 3 anesthetic solution is being missed out. So it's not a lacuna in that particular study, but that is the gap in the knowledge. We won't be knowing which is the best anesthetic solution. So that's why the network meta-analysis plays a role to give answer for our question.
Yes.
Okay.
Yep.
Thank you.
Great. Arvin?
Okay. This table shows and explains us the risk of biases, and as you see in the subtitles, the green columns mean that everything is okay, and the study has low risk of bias in the field that has been shown, but the yellow columns show that there is some concerns in this part of the methodology, and as you see here in, for example, in the first, third, and fifth article, there has been some concerns in the bias arising from randomization processes. So this article's reader has found some issues of concerns in these parts, and beyond that, they found the red columns. It means it has high risk of biases in measurement of the outcomes. So overall, they concluded that these 3 articles have high risk of biases, but they put these articles into their investigations, but have mentioned that these 3 have high risk of biases, and also I think they done another conclusion with excluding these 3 articles, and they make a bit different conclusion by excluding the high risk of biases. I saw that Professor Venkateshbabu was a bit about when I said they excluded. Didn't you do that? I think at the end of conclusions, you have 2 conclusions, when including the high risk of bias trials and when excluding them. Am I right?
Yeah.
Okay.
Yeah. Excuse me. Could you hear me?
Yes, please.
Yeah. Are all these studies in index journals? I'd like to ask, is it a factor in your mind while doing this study? For example, should it be in citation index or citation index expanded, or the type of the journal, the values in which type of the journal? Is this a factor in your mind while doing this study?
Wenki, the question is it important, for example, to publish something in IEJ or JOE, or if it is in a journal which is not very high ranked in terms of scientometry, still, are you going to look at that or not?
No.
No.
So here, risk of bias means my focus is how the way of trial is conducted. My focus is not seeing that where that particular study is being published. You got my point?
It's not important
thank you.
where it is published.
Yeah.
Yeah,
For
yeah.
example, few studies can be published in IEJ, JOE, JDR, or whatever. But
Maybe
the
you
way
don't check,
of-
but it can be in your mind. Is the factor?
no, it won't affect.
No.
So
Okay.
that's a
Thank you.
different game, and this is the different game.
Thank you.
Even I think in the systematic review, we look at the gray literature even.
Yeah.
Yeah.
Even that
Yeah.
also will contribute.
So we don't mind actually if something published in a journal or even a thesis somewhere around the world,
Yeah.
if the data is valid, if the methodology is valid, if the technique that they use is valid, we still need to add those data to the pool of the data. So it is not a big issue where they publish it.
Yeah, exactly.
Okay.
Thank you.
Thank you very much. Let's continue on. Now we reach to the forest plot. As you see in this forest plot, we have different kind of, I have two slides for forest plot. As you see, the first part have these studies that have compared articaine versus lidocaine. The second part have compared mepivacaine versus lidocaine. The third one, prilocaine versus lidocaine. In the next slide, mepivacaine with articaine, and so on. So let's go through each comparison. In the first one, we see that we have a comparison between articaine and lidocaine. And as you see here, just one study, this study, Ahmad, have concluded the, let me first explain about the forest plot a bit, and also Professor Venkateshbabu can add anything that he wants, and it would be our honor to have it, because as you know, forest plot is a bit difficult to interpret. As you see here, the factor that this study have used for forest plot is risk ratio. The risk ratio compared, but I think when I was reading this article, I think the risk ratio was the same meaning here as success ratio, in my opinion, because as you know, risk in the statistical means have a bad meaning, a kind of bad meanings. But here, risk, I think when I was reading, it's better to say success ratio. But when we are going to draw this table, we have to use the statistical words, and here a good proper statistical word here is risk ratio. So as you see, this is the line of no difference, and for a risk ratio, this line should be at 1. The numbers and the rates more than ones means our first solution that has been written has the more success rate and have the more efficiency, and the numbers lower than 1 till 0 means that no, our first solution have less efficiency compared with the second one. As you see in the results of this, I think 9. Yes, 9 studies. Nearly all of them have the higher risk ratio, higher than 1, and it means that generally articaine is more efficient than lidocaine. But when go through all of the articles, we see just this study. Ahmad's results has been statistically significant. Why I'm saying that? When looking at risk ratio and confidence interval, it's very important to know when our confidence interval cross 1. As you see, all of these confidence intervals has crossed the 1 number and goes below than 1, so it means that it's not statistically significant anymore. Don't pay attention to the risk ratio is more than 1 when its confidence interval has crossed the 1, so it's not statistically significant. So just the Ahmed study has been statistically significant, but a very interesting result when pulling all of this data with each other and combining them with each other, we see that the overall and the total subtotal result is meaning. So did you understand what I said? Just one study between these 9 studies was statistically significant, and 8 of them's result was not statistically significant. But the overall and the subtotal result has been statistically significant. Why? Because its risk ratio for comparing Arctic versus Lidocaine is 1.16, and the confidence interval has not crossed the 1, so it's statistically significant. And just mentioning the I-square that shows heterogeneity or homogeneity, it's lower than 30 or 50, it's 3.4%, and also its p-value is higher than 500, more than 0.50. It shows that our articles are homogeneous.
Okay, Wenki, are you happy about the way that Arvin explained that?
Yeah. He understood the concept behind this forest plot and everything.
Yeah.
But what I will tell like this, right now we have only 20 minutes of time. So the most important in this particular paper is the next coming things. Here, whatever which he is explaining is only related to meta-analysis. So now our main focus is network meta-analysis. So I am asking him to go to that slide to explain this more better.
Okay. Arvin, make it quicker.
Okay. And after that, as you see the other comparisons, maybe Mepivacaine versus Lidocaine, it has been again so I only just speak about the total result. As you see, it's 1.46, and it's more than 1. So again, it's statistically significant, and Mepivacaine has been shown to be more efficient comparing to Lidocaine. About comparing Prilocaine versus Lidocaine, there is only one study, so it's defects or it's a gap in the studies that shows that Prilocaine has not been investigated enough to be meta-analyzed by the writers. So it's just one study that has investigated on them, on these 2, and as you see, its result is not statistically meaning and significant, and as you see, the confidence interval is high. Again, Mepivacaine versus Articaine, it's not meaning. Prilocaine versus Articaine, it's not statistically significant. It has been passed to 1. Prilocaine versus Mepivacaine, again, the same. And Bupivacaine versus Lidocaine, it's past the line of no difference, and it's again, it's not difference, and it's the same for Bupivacaine versus Articaine. So here in this figure, we see network meta-analysis. This network plot is combined of 5 anesthetic agents on success rate of inferior alveolar nerve block. Let me explain first that the size of the nodes is correspond to the numbers of trials. As you see here, the Lidocaine has the largest size comparing to the others. I think it's very clear and it's very obvious that why it has the highest size, because as you know, it's a kind of standard for us to comparing our solution versus some solution. All of the clinicians use lidocaine to compare the other solutions to that, so that our lidocaine has the highest number, and after that we see articaine is the second one, and it shows that the most of the studies have compared articaine versus lidocaine or versus others, but it's not important. But it's important that we see the second field of interest in the solutions after lidocaine. That's standard is articaine, and after that mepivacaine and bupivacaine and prilocaine are the others. And as you see again, here's the here the prilocaine has the lowest size, and it shows that our studies on prilocaine needs to be more improved and be more far better. Beyond the size of the notes, it's better to emphasize on the largeness or the thickness of the lines between the solutions. It shows that how many studies have compared the two solutions. For example, the thickness of this line shows that the studies that have compared articaine and prilocaine are low. But this thick line shows that the studies comparing lidocaine and articaine are high, and so on. If any other question is there here, I can answer, or if no, I can carry on.
I think Dr. Ramazani, Mohsen, do you want to add something? Mohsen, turn on your microphone, please, if you want to add something. Microphone, please. We cannot hear you, Mohsen. Okay, yeah, go ahead.
Okay.
Hi, everybody in this meeting. Thank you very much for this presentation. I have a question from the first author of this article, which is why is the most solution compared in this, in fact, in the recent articles published worldwide, in the important articles, especially JOE and International, is the lidocaine and articaine. Why the researchers are not interested to compare the others, to in fact close them to the lidocaine and articaine in case of the amount of researches and publications?
Wenki, please.
Yeah. Now the most important controversy is going in endodontics is which is the better anesthetic solution is versus lidocaine or articaine. So that's why one trial is suggesting lidocaine is better. The next trial is saying articaine is better. So that controversy is existing between these two anesthetic solutions only. That's why if you see this, totally we have 5 or 6 systematic reviews saying lidocaine versus articaine with controversy results. Again, systematic review also you have a controversy results between these two anesthetic solutions. So that's why recently me, Prof. Nekoofar, Prof. Paul Dummer had did an umbrella review. You remember Prof. Nekoofar saying that which is the best anesthetic solution comparing lidocaine and articaine. That is one step more than your systematic review. So we combined all the systematic review assessing the lidocaine and articaine, and again we suggested based on our results which is the better anesthetic solution. So that is how the is most popular between this lidocaine and articaine, because we have a lot of controversy results. That is the issue.
Wenki, do you want to add something for this diagram that we can see right now?
Yeah. He explained it very clearly, but I would like to give a little bit more clarity on this image. If you see this image, first I can see 5 dots. Okay, it means 5 interventions have been used in this study. This is first interpretation. Next interpretation is the size of this circle. If you see lidocaine is more, prilocaine is small. It means the number of studies is more in lidocaine, number of studies in your prilocaine is little bit lesser. The next interpretation is the lines joining between these 2 dots. If you see that the line between lidocaine and articaine thickness is more, it means among these 11 studies, these 2 combinations we have more number of studies. Okay, this line says these two studies, two dots means this two anesthetic agent has been connected. Whereas if you see clearly this image, there is no line between bupivacaine and mepivacaine. You got the point? So what is the take-home message? There is no direct evidence between bupivacaine and mepivacaine. So that's why I am doing my network meta-analysis. One more thing, I don't have any straight evidence between prilocaine and bupivacaine because I can't find any line there. So that's why network meta-analysis helps you. Okay, this is the interpretation from this particular image.
Okay, is there any question related to this image? Because I think this image is very informative, put everything together. This is the heart of the network meta-analysis.
Yeah.
Professor Venkateshbabu, may I ask you a question from you?
Yeah, please.
As you know better than me, we have a direct comparison between the dots and indirect comparison between
Exactly.
Can you explain us about because direct comparison is a bit clear, but can you explain us about indirect comparison between these stations?
I think you have given the table here now. The next slide.
You mean this table? Let me go. You mean this table?
Yeah, exactly. If you see this table, you can see 5 groups, right?
Yes.
Artivicaine, bupivacaine, mepivacaine, prilocaine, and lidocaine. The upper boxes is a direct evidence. It means articaine and bupivacaine 2.00 is my value. Bupivacaine and mepivacaine, NA means not applicable, means no studies has been published. The first half of the box is the direct evidence.
Arvin, can you use your cursor to show the place that Wenki is explaining?
Yes, he is explaining about the upper right part of
exactly.
right part of the table.
Okay.
As you see, see, excuse me, Prof.
Okay, Wenki, you go ahead, and Arvin, just you show me the cursor.
Okay. Yeah, as Arvin said, the upper right half of the box, right from this articaine to this lidocaine, is the direct evidence. For example, direct evidence between artivicaine and mepivacaine, the values goes for 0.88. Okay, it means articaine and mepivacaine is joining at that particular point. So that is the direct evidence. Whereas articaine and mepivacaine indirect evidence goes to lower border, that is 0.85. Articaine versus mepivacaine.
Yes.
Yeah, you got it? So this is how you have to interpret your direct evidence and indirect evidence. So in my putting my indirect evidence, I am including the studies from artivicaine, bupivacaine, mepivacaine, prilocaine, lidocaine. I am including these 5 groups and putting into the statistical analysis. Then only blue color is 1.42. That is mepivacaine versus lidocaine. So it means mepivacaine is better than the lidocaine. Whereas if you see this direct evidence, also is 1.46 means mepivacaine is better than lidocaine. So what I'm trying to say from this table is both my direct evidence and indirect evidence is supporting the mepivacaine. Whereas in direct evidence, I am comparing only mepivacaine versus lidocaine. Whereas in indirect evidence, I am comparing 5 anesthetic solution. In that 5 anesthetic solution, only significant is mepivacaine compared to lidocaine. So it means my mepivacaine score is better. That is the take-home message from this chart.
Very nice.
So that's why this chart we have given in the main manuscript. Rest all those things are, we gave it in supplemental document.
Great, thank you very much. So don't worry, please, sorry, because of the time, Mohsen raised his hand. Mohsen, please, you go ahead, and then Fatima. Mohsen, please.
Yes, you have my voice?
Yes.
Yeah.
You have my voice?
Yeah, please go ahead.
Thank you. I personally think that one result from this table and the previous drawing you showed is a good point for the researchers to conduct the new researches in the future. In case of comparison between the anesthetic solution, for example, in case of a comparison between bupivacaine and mepivacaine, there is no direct comparison in the publications. And this is a good point for myself, for example, to do a comparison in the future. And this need is in fact felt by the science of endodontics to be done in the future. Am I right?
Yeah, exactly. That is the right point. So that is why we are doing the network meta-analysis. It will give you the scope for future research. As you said, no studies between bupivacaine and mepivacaine. You can do study. The one more thing is indirect evidence shows mepivacaine is better than lidocaine. But any day, in case if the results is differ, any day we prefer direct evidence. It means we have to go for future clinical trial in that particular aspect. That also is one more take-home message.
Thank you very much.
Thank you. Fatima?
I have a question. Do we use a node splitting analysis to provide this indirect evidence?
No, sorry, I can't hear you. What I say?
Can you repeat,
please? Do we use node splitting? Node splitting.
Node splitting.
Yeah, that is one of the method. That is more into the statistical part. Yeah, node splitting will be done. Yeah, that's more related to statistical aspect. The statistician will take care of all those things.
Is it used to provide the indirect evidence? I mean,
yeah,
yes.
It helps in providing indirect evidence.
Yes.
So
thanks.
Your question is, what is the methodology to be followed for indirect evidence is node splitting method. That the statistician and that particular expert will be doing that and splitting it up, and then we will be giving the values to us. So from that we have to do our interpretation.
Okay, Arvind.
Professor Venkateshbabu, now that we are here on this table, can I ask you a question about the subtitle of this table? Let me share my PDF. Do you see this?
Yes.
Can you see my PDF?
Yeah,
okay.
Yeah.
Here you see it's been written that for the pairwise and network meta-analysis, a risk ratio more than 1 indicates that the treatment specified in the column is more efficient. Is it correct? I think just for the lower left part, it's the solution that's been written in the column is most efficient. About the upper right part or pairwise, the solution that's in row is more efficient. Am I right?
Yeah, that's true. That's how we made it as a blue color marking, right?
No. I'm speaking about the meaning of this subtitle.
Okay, good. So you want to know what is the meaning of that third line, right?
Because it's been mentioned that for both.
See, I have mentioned in the third line 1. Okay, if you see this blue color box, see a confidence interval is 1 is coming in between.
What? I didn't understand.
Number 1 will come in between 1.02 to 1.32.
Exactly. Yes.
Yeah, exactly.
Okay. Yes.
No, in the blue one. In the blue on the right side, upper
one. Yeah, upper right. For example, 1.6 bracket. You have 2 numbers, correct?
Yes,
1.02 TO2 1.32. Is 1 is coming in between these 2 numbers?
Yes.
Yes.
No, 1 won't come. See,
because 1 is not between. Oh, yes.
Okay.
Yes.
Okay. If you see this next cell, this is white color, 0.47 to 2.15.
Yes.
This 1 is coming in between. Yeah. So that's why the thing. If this 1 is coming in between, it means no statistical difference.
So it is very similar to forest plot. Am I right? It's very similar to the way that we. Yes.
Exactly. That is all. So that's why if you see this blue color boxes, 1 won't be inside. So it means it's.
I know, Professor. I mean another thing. you see here in the subtitle, it's been written that for pairwise and network meta-analysis, it means
Yeah,
that for those portion of the table,
yeah.
a of ratio more than 1 indicates the treatment specified in the column is more efficient. Okay,
Yeah,
I
yeah.
think it's just right for the meta-analysis, not for pairwise, because for pairwise the solutions specified in the row is more efficient, not for in the column.
No, no,
You
no,
know,
no, no, no. Here, pairwise means upper half.
yes,
Network
upper right,
is a
yes,
lower half.
yes, yes, yes.
So that's why it had made it very clearly like that. So in the same image, whatever this rule applicables is significant. That's why it's in blue color. So that will
Okay,
be the take-home thing.
okay, thanks.
Okay, Arvin, make
Yes.
it quicker.
Okay, yes. Let's go through our, where did we, yes. About this network meta-analysis, a network plot of 4 anesthetic agents of success rate of inferior alveolar nerve block, including studies with only molar. There are a kind of subgroups for the network meta-analysis. As you see here, the size of nodes has been a little bit smaller, and it shows that it's a subgroup, and it includes just the molars one. And the other subgroup is a network plot for 4 anesthetic agents on the success rate of inferior nerve block when we exclude high risk of biases. It's very important to note that we see when we exclude the high risk of bias studies, we lost the one of our solutions, that's Prilocaine. It shows us only the high risk of bias studies have investigated on Prilocaine, and when we exclude them, just 4 solutions remains for us. We talked a lot about this table, so we skip this and we go through this rankogram or supra-ranking, different meanings that it has. What should we notice here? You see, we have 5 solutions: Arctic and Bupivacaine, Lidocaine, Prilocaine, Mepivacaine. So it's very clear that we should have 5 ranks because they are going to rank with each other. The solutions that has the highest part under the line, it's a higher surface under the line. In statistically speaking, we call it has the higher supra ranking, so it shows that it has higher rank. Let me explain a bit more, and after that Professor Venkateshbabu may help us more. As you see, for example, for Mepivacaine, the probability that these solutions being in rank 1 is higher than all of the other solutions. So and also it goes higher because here we see that written it's cumulative probability. So cumulative means the probability of being rank 2 will be add to rank 1, and then it will be shown here. So it's very important that then our surface under the line for each of the solutions is high. As you see here is 81%. It shows that these solutions, these specific solutions, got the higher rank comparing to the other solutions, so it has the higher efficiency in our network meta-analysis. As you see, the second solution is Prilocaine that has 62. Where does this 62 comes from? From dividing this surface to the whole surface. It shows it's more than 15. It's about 62%. So it shows that it's the second solutions for us. And after that, when you see in the rankograms, the next solution is Articaine, the next one is Bupivacaine, and again the least one is our standard that we use to compare the other solutions to it. That's Lidocaine. As you see, it has the lowest surface under the line, so it has the lowest supra ranking in this meta-analysis and network meta-analysis. So it shows that the probability of lidocaine to be in the rank 1, 2, or also 3 is about 0.
Wenki,
Any other?
we need your description a bit more about that.
Yeah. See, if you see this particular slide, it says Sukra ranking. It means, Sukra means surface cumulative ranking score. So if you see this picture, I have 5 groups. I have 5 graphs. If you see this graph, the cumulative probability towards my outcome. So my outcome is which is the best anesthetic solution. So the cumulative probability is more towards which anesthetic success or anesthetic solution is the take home from here. If you see this, mepivacaine, it shares around 81%. It means the success of anesthetic agent, success of our outcome is more in your mepivacaine. That's why this has been scored number 1. Same way, number 2 goes for prilocaine, 3 goes for articaine, 4th goes for mepivacaine, and last goes for lidocaine. So this is how the take-home message from your this particular slide. So this will be reflected in. Arvind, can you go to the next slide, please?
Yes. It's another diagram that has been resulted from this.
Yeah. So this will be the ranking. So my rank 1 goes for mepivacaine. That is almost, as I told you, it's around close to 80%. Then followed by prilocaine, it will be around 60. Next is articaine, it will be close to 50. Again, mepivacaine, it will be close to 40. So this is how the ranking shows here.
Thank you very much.
Yeah.
About this table, it's a supplemental table that shows result of network meta-analysis. As you see here, there's no additional information here, just to emphasize on the these parts that shows that our
this is the same table for easy for the readers. I have extracted and give it in here. See that? For example, this is the meta-analysis value. This is the p-value. This will be your Sukra value is 0.81. That's why the ranking will be number 1. Heading is only for primary analysis. Alvin, can you go to the next slide?
Yes.
Yeah. This is the combined my table. If you see that, first heading is intervention. Next to intervention is primary analysis, including all these studies, including 11 studies. The next is sensitivity analysis, means I am excluding high risk of bias trial. Means indirectly, what does it mean? I am including good quality studies. So in that also, my ranking number 1 goes for mepivacaine. For prilocaine is not applicable, means there is no good quality studies under your prilocaine agent. That is the take home here. If you see this next block, again subgroup analysis only in molar. Because in 11 studies, few studies they have used premolar, few studies they have used molars, few studies they used both premolars and molars. So little bit to focus more, I have focused only the studies with only molars. I tried segregating only with premolars also, but I can't unfortunately do that because of number of studies is very less. That's why I think I have mentioned in the limitations or somewhere in discussion, saying that I can't do this because of my limited number of studies. So this is the table which gives you the whole picture.
Yes. Very nice.
Sometimes in this, sometimes excluding the good quality, excluding the bad quality studies, mepivacaine is number 1. Sometimes we don't know. Suddenly, articaine would have been be better. So then, at that time, we have to take our results little bit too cautious.
Yes.
So that is the take home. So that is how the grade will reflect. If you see the another side, you would have been giving the grade. It will be reflect with that.
Yes, that's great. Very good. Okay, let's continue. And this is also the same table as the previous with the higher informations. that Professor Venkateshbabu explained very well. I think we can skip this slide because it's the same of the previous one. And now let's go through the discussion and end of our presentation. As we see, the result of this network meta-analysis indicates for us that mepivacaine with epinephrine may be more suitable than other anesthetic solutions tested for achieving pulpal anesthesia bar inferior alveolar nerve block for treating our irritabilities that have irreversible pulpitis. It performed better than in this descending order is articaine, bupivacaine, and lidocaine. So articaine after mepivacaine is the second one. While articaine also provided to prove to be more effective than lidocaine or bupivacaine, it was shown together with pyrlocaine to be associated with significantly increased rate in paresthesia and increased risk of methemoglobinemia. So it's very important to for us that we know that it's true that articaine is the second one, but as you see, it has this risk that has been mentioned here. Mepivacaine may also present a valuable alternative. It's been a result from this article. So the use of local anesthetic should be guided by proper case selections, anesthetic techniques, and those to minimize the risk of our complications by using this solution. About the strengths of these studies, the included studies were conducted from various countries, and the age range was a good range from 18 to 57 years. So it shows that this result of that concluded from the systematic review should be applicable to a wide range of population and applicable to anesthetic efficacy in mandibular teeth with irreversible pulpitis. So it's very good for us that this range has been applicable for the wide variety of the range. And the limitations of this study was pyrlocaine that was included in the systematic review as it is an effective and widely used anesthetic solution, but the problem was the resulting that comparing pyrlocaine with other solutions was from the studies that had high risk of bias, so it should be reviewed with caution, and we should consider some issues and some concerns using this as a high success rate, because it, as I said, it was in the high risk of bias studies, and beyond that, the numbers that has used pyrlocaine is very low. So maybe it's a kind of again a knowledge gap that it's good for our researchers to fill this gap with researching on pyrlocaine in the comparison to other anesthetic solutions. The general conclusion that we conclude from this article was that the Nekoofar meta-analysis showed us the mepivacaine with epinephrine performed better than lidocaine with epinephrine in achieving higher inferior alveolar nerve block success rate in teeth with irreversible pulpitis, and also, as you see, it was ranked the highest amongst the other solutions. But the network meta-analysis, including only low risk of bias studies, revealed no differences among the 4 anesthetic solutions. So future high-quality randomized clinicals are needed to confirm the result that we have concluded in this review. Thank you all of us to joining us.
Very nice, very nice, Arvin. Arvin, well done, well done, very good. I'm very proud. Venki, what do you think about Arvin?
Yeah, exactly. It's a good presentation, because without having the basic idea, you can't present what is network meta-analysis and all this key component. He understood everything in very nice way. I don't know how he understood all those things.
Yes,
it's a very
Venki,
he has a good guide, Professor Nekoofar.
Yeah, Rohit, before you go, I'm going to say something. Arvin is our Venki in Iran.
Oh, wow, very nice. Oh, great. Great, great.
He's one of the very important scientists in Iran. I hope he is now in the second year as our resident, and I'm very proud that we have a very good resident like him between us.
Very nice. Very
and
nice.
I think next time Fatima is going to show you something as well. She is one of the stars as well. Okay.
One question, please. One question which I wanted to ask you initially, but I missed out on this. Venki, the cases with irreversible, symptomatic irreversible pulpitis were included, or asymptomatic irreversible pulpitis were included? I need a clarity on that a little bit. I think I didn't understand that.
Yeah. Here in this review, we have never focused on that particular point because few studies they have included only symptomatic, and few studies they would have been excluded asymptomatic. So based
I
on
think that's
whatever,
I think that's a very important issue.
yeah, that's one of the most confounders which play a key role in outcome of our review. As you said,
Correct.
diagnostic status and preoperative pain status also will play a key role. But
Exactly.
unfortunately, in these 11 studies, I can't do subgroup analysis with those individual parameters. So that's why we missed all those criteria there.
Because as we see in the daily practice, the teeth with the symptomatic irreversible pulpitis are much more difficult to handle than, you know, even Nepivacaine in some cases wouldn't work.
Of course, I do agree with you. Because the hot pulp situation will be more in symptomatic situation.
Exactly. Nothing less than intrapulpal.
And we need to be very careful about not not overgeneralized, because if we overgeneralize this result to other things, like as you mentioned, Rohit, we need to be very careful, because the specific question of this study is very clear, and we need to use that as the conclusion, not anything else. So extrapolation is very, very dangerous. It's one of the big pitfalls of evidence-based. Yeah, thank you very much. That is a very important issue that you mentioned. Thank you. Okay, Professor Baber.
Thank you. Thank you. I'd like to emphasize once again, we are very happy to be here, and I'd like to thank Arvin and Professor Venkateshbabu and you, Professor Nekoofar, for inviting us to this high quality presentation and discussion. We are very happy to be here. Please, but please do us a favor next time. 8:30 is too early for us for Sunday. Please, we will be pleased if it can be later. 1 hour is enough. Thank you very much.
Okay, what I'm going to do maybe for the next session, I'm going to prepare some sort of poll and send it to everybody about the time. What is the best time?
Thank you.
So
thank you.
In Malaysia, for Wenki, it is evening, so it is difficult for Wenki somehow. For us, it is 10 o'clock in Tehran. It is in the middle of everything. And, you know, Sunday we are working, but you don't work, so you are at home. So these are the things. So we need to find out the best time.
And these are the lockdown days, and we go to bed very late, and we slept only 5 hours.
I know you are working at night as well. I know that.
Invitation. Thank you for the invitation.
Any others? Senem, do you want to add anything? Marriage, please feel free to speak.
Mohammed, it was a very nice presentation, and it was very understandable for us to make some conclusions, good conclusions. Thank you for this opportunity again, and we're looking, we're very excited for the future ones. Thank you for the kind invitation. I wish Arvin will get good results from this presentation, a high mark. Thank you, Arvin.
Thanks
and thanks to all.
Thank you very much. Thank you. Mary.
Thank you. Thank you.
I would like to thank you for the opportunity again, and I want to congratulate Arvin for this outstanding presentation. And it's like a storytelling by means of existence of Venkateshbabu. It's like a live article becomes alive, so it's very enjoyable as well. I'm looking forward for the future sessions, and of course, many great thanks to Dr. Nekoofar for invitation.
Professor Zaga.
Maybe Dr. Nekoofar, I have an offer. Maybe the international jury may help you about marks.
All right. Yes, international jury for Arvin. That's a good idea. We will think about that. Maybe next time some schools from Turkey or from India They can choose one of their residents to present. Why not? We need to arrange, we need to think about that. So gradually it will grow and we work to each other unitedly. And this is the opportunity that we get from this damn COVID-19 virus.
To Arvin, 10 points, 5 stats.
Thank you very much. Professor Zargar.
Professor Nekoofar, one request
yes,
to
please,
all.
Please, Professor Kochler, please.
If everybody could introduce yourself, all the faculty here, if they could introduce yourself on this arena, we would have a better connect.
Yes, it is a very good point. Professor Baber Kayahan, you start quickly, quick introduction.
Yeah, I'm working at Okan University in Istanbul at Endodontics Department, of course.
So now I know whom to contact when I'm coming to Istanbul.
Yeah. I can send you my email, and we can also create a pool for the emails. It will be better, I think.
Yes,
yep.
Yes.
Yeah, that's a good idea. We will do that as well. Okay, Professor Venkateshbabu, I'm going to ask you actually to introduce yourself again, but we know you very well because you are one of the very young star in endodontics world.
We are a fan of him.
Yeah, I'm Venkateshbabu. Currently, I'm working in International Medical University, Malaysia. Basically, my bachelor's, my master's, and doctorate is from India. Hope you know Chennai, right? Tamil Nadu, Chennai. So I did my 3 degrees, my bachelor's, master's, and my doctorate there. And then I worked as a faculty for a couple of years. Then I moved to Malaysia. Currently, I'm a full-time faculty here in International Medical University.
Thank you very much for accepting our invitation. And I would say that now you should introduce yourself as the visiting professor of Tehran University of Medical Sciences as well. Yes. Professor Kumars, please. Professor Kumars Nazari, you introduce yourself. You should come a bit upper, then we can see you, because we just can see your eyes.
Okay. Thank you very much. I think among the lecturers
please introduce yourself. Kumars, please introduce yourself first.
Okay. Among the colleagues, I have nothing to say. I think it's better to speak about Professor Venkateshbabu. I think is the best statisticians, and I think it's difficult, as you know, knowing about the math and other related science. I think is very difficult. So I think it's the best way to improve your knowledge about the aesthetics. Having a person like is very important and brilliant, because he was familiar with different kinds and difficulties that we have encountered in clinical situation. And it's the first time that I saw many new software, and it's the best person that I have ever seen in this field that describe and many things very well. And I thanks to the professor that it is possible, as I said before, to give us more information, some things that you have written or as a PDF format of Word in statistics. And I think we have no information idea about the statistics. This the drawback of our endodontists, that the knowledge about the statistics is low. So it is possible for us to join to all of the journal clubs that will be heard in future and give us more information about it. Thanks a lot. Thanks a lot.
Yep, thank you very much, Wenki. Professor Zargar, you introduce yourself, please. Professor Zargar, can you hear
everybody.
Us? Yeah, please.
Yes. Yeah.
Yep, go ahead.
Hi, everybody. Thank you for your presentation. Thank you, Dr. Nekoofar, for this chance. And I'm glad to see everybody in this community, and only I'm a student here.
No, you're not. Actually, and, Professor Zargar is the moderator of postgraduate endodontic course in Shahid Beheshti University. Shahid Beheshti University is the main competitor to Tehran University of Medical Sciences. So somehow she's an enemy, but I'm trying to make her as a friend.
Then why did you accept her to this discussion?
No, we are very close friends, to be honest.
Of course, I know. Of course,
in terms of the university, we are enemy. You know, that's difficult. So, and then also we have that opportunity.
We are friends now.
Yes, we are
regards
friends.
Regards to Prof. Zagar.
Yeah, yes. And what we have actually, I'm very proud that we have Professor Doris. Professor Hassan Doris is our ex-dean of Tehran University of Medical Sciences, School of Dentistry. Professor Doris, can you give us some good word, please? Can you turn on your microphone and speak for us, please? Thank you very much for joining. Professor Doris is a prosthodontist, by the way. He is not an endodontist, so he is a guest, not an enemy. Professor Doris, we cannot hear you, unfortunately.
Yes,
so
on mute.
we have also another guest, Professor Ansari from Shahid Beheshti University. He is a pedodontist. So I'm going to ask Dr. Ansari to speak, please. Dr. Ansari, please turn on your microphone. Dr. Ansari, we cannot hear you. Please turn on your mic. Okay, please go ahead.
Yes. Hi, Professor. How are you doing?
Thank you.
Very
Please.
nice presentation, and I really enjoyed, despite me being on another online class with my residents. I missed a big part of it, but I really like to congratulate you and all the other members of the team with this fantastic presentation.
Thank you.
As you said, we are more like friends and colleagues. Do not call Beheshti and Tehran as enemies.
No, that's
Keep,
a joke.
the, shall we say, nice side of it together. We have managed to bring more than 10 universities from different parts of the world together.
Exactly.
And we are much closer. So we appreciate your closeness. Take care and have a nice day.
Thank you very much. And we have also Professor Bakhtiar from Canada. If she can hear me, hang on, can you speak up, please? I think this is midnight in Canada, but she is still connected. So I don't know, can she hear us or not? Please turn on your microphone and speak up. While we are waiting for her, Mohsen, do you want to add something?
Thank you again for this beautiful and informative presentation. I am a beginner in case of endodontic research. I have nothing, in fact, to introduce myself. I'm your student and the other professors in this meeting. Thank you. Thank you.
This is the Iranian way. Everybody tries to say that they are very humble. Okay, guys, I think the punctuality is very important in international relations. So we start definitely at that time that we arranged. Tehran time was 10 o'clock. And now it is 3 minutes to 2 hours for this session. So I'm going to close the session by the memory of our late Professor Kazem, Dr. Kazem Ashofte-Yazdi. And so we are going to pray for him and for his soul. So we are going to recite Surah Hamd and also 1 minute silence again for him. It was last week, unfortunately, in the middle of the meeting. I understand that we lost him on the same day. And he was one of the really very good and energetic dean of the Endodontic Department of Tehran University. And unfortunately, because of the heart attack, he passed away last week. So 1 minute silent and reciting Surah Hamd. Thank you very much. So we are going to finish the session. This session is also recorded, and I will send you the link if you want to listen again, because I know the topic is very difficult and very difficult to understand sometimes and confusing. However, Arvin and Venki did a very, very well job and clarify everything for us. I'm not sure exactly about the next session, what we are going to do, but I will inform you through our communication that we already have. Thank you very much for your support and for joining us, all of you. And if I forget the name of any of you, please accept my apology. Hope to see you very soon again. And I'm sure APEC, with the presence of the President Mehmet Bey Burakayahan, is going to support us. And the Education Committee of APEC is going to support this meeting. Hopefully, we are going to have a larger group altogether. Thank you very much. Have a very nice day, all of you. Goodbye.
Goodbye to all. Thank you very much.
Goodbye.
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 Goodbye. Thank you.